Rachel. You passed both. I was reading your email now, and tell
Oh,
everybody what you did, because I
oh
think that
yeah,
is I think that is
yeah,
the smartest thing you can do. I mean, honestly, I
yeah.
I find
Mhm.
before you start, Rachel, I find myself heavy-hearted when I see people not passing and they didn't even try the diagnostic test. I don't know why they would not do the diagnostic test. I mean,
Yeah.
that is craziness.
I did everything. I failed August. I
Yes.
tried, but I was not prepared at the time.
Also,
And
I'm sorry, Rachel. Hold on. You failed the first time.
yes, I failed first time. It was August.
Okay.
So I was
Did you
really
hold on, Rachel? I'm sorry.
Mhm.
You fell in our class.
No, no.
Okay.
People I
Okay.
met you. And then I was like stay back like 1 month, and then I met you like September 23rd.
Okay.
I start to study. So I follow your program. I did everything. Test bank, I did 5 times. And then crash
And then
course,
you ask me for more.
yes. And crash course, education, I did 5 times. And the all crash course, at least 4 times. And I found out your last version, that was test 4. So I did it. I did it twice. And
Wow.
then,
You really want to pass.
yeah,
Yeah, I mean, I don't recommend it go all in like Rachel, but I,
I
you
did.
know, but
I
you
was
saw the results. It
Yeah,
came, right? You
I
saw the
was
result.
very desperate. And then
Yeah,
that
I
is my first
know.
time to fail the class for my life. It's my
Yeah,
first time to fail. So it was really hard for me, yeah, to accept it. So
but Rachel, here's the thing, right? Schools do not teach you guys how to pass the
no,
board.
nothing, nothing. I'm
And
telling
plus
you.
there is a lot more knowledge that goes into
Yes,
this
yes,
class. And
absolutely,
and I'm not trying to sell
absolutely.
anybody. Everybody that's here is probably in the program, but there is nothing like our course because it takes time. If I open my email right now, I can show you I'm behind 150 emails. Because who would be spending that much time? Honestly, we do, and that's what we want. We want you guys to feel heard and answer your questions, but it is tons of work, but it brings results.
So
It-
I was in Boston to see my daughter during the Thanksgiving. I studied there. I didn't go out. They say, "Mom, why you are here? Let's go out. Leave me alone." So I studied there. Even airport, even the airplane, I studied to that.
okay.
So I'm very glad that I met you. And then, so yeah, I'm gonna take the pharmacology class too. So I'm gonna send you an email. But yeah, I'm gonna do ANCC, ASCFP.
Uh-huh.
Thank you so much, Dr. Lopes.
Well, when are you taking the A and C?
ANCC, I didn't set up yet, but I'm gonna do ASCFP.
Yeah, please, please, please don't rest on your knowledge, because
No,
that is a
no,
common mistake
yeah.
people do. Sometimes people sign up and they stay in the program a
Mhm.
while, but then don't test it. So you are hot
I
and
will
fresh
do it.
right now. Make sure you go test it immediately, the
Okay.
soonest as possible. You don't even have to wait for the crash course review.
No,
You
no.
will,
Will
yeah,
do.
you will pass. So
Yeah.
don't, if they have available next week or two
Yeah.
days, don't delay. Go
I
test
will
it.
do it.
You will definitely
I will.
pass. So yeah,
Thank you so much.
congratulations. It must feel nice to,
I
you know.
cried.
I know. The board is an emotional thing, guys.
Yes.
People take it lightly, and oftentimes they don't get the results. I mean, this is not a walk through the park. It takes a little bit of work, but it's a sure path to success. I promise you, if you follow the program, uh, you will pass. Now, I have a lot of folks that come in and say, I'm testing tomorrow, the next day. We can still probably, a lot of people have done it in 2 days or 3 days, to be honest with you. But, the passing rate really falls down a lot when people are rushed, because whatever reason that might be. right? So timing a course is the smartest thing anyone can do. And we allow people to join 6 months early, and we don't kick them out. So we, just come and do and learn and pass. All right. Is anyone stuck on how to join the Kahoot game? Once I start the game, I can't help you.
Yes, Dr. Lopez, I'm stuck. I don't know how to
Okay.
join.
All
I had
right.
the same
So
problem last week.
grab your phone
Got it.
and
Yep.
and open your camera to the QR code here on the screen.
Okay.
And then you see a hyperlink. Once you see a hyperlink, click on that and then create a name, a nickname for you. You can call yourself whatever you want, your real name, your fake name, doesn't matter.
Okay.
And then you are in the game once you see your name popping up right here.
Okay.
Okay. So Kahoot is an interactive game. That means that you'll be playing on your phone. You'll be playing on your phone. And it is
Alright.
only 1 minute per question. I can't stop the questions once I keep on going. Okay, so we're about to get started in a minute or so. So I'm giving everyone a grace period. But
thank you. Thank you.
All right, great. Is anyone stuck and still confused how to join? Group at.
Yes, Dr. Lopez.
Hi, do you have a question?
Yes, I just put in my nickname and it said achievement, but I don't know if I'm in or not.
Do you see your name here?
Bottom, but I don't see other people yet.
No. Do you see your name?
Yes.
Okay, then you are in. You gotta wait for the game to start so you can start playing.
Oh, so am I going to be using my laptop and my phone at the same time, or I'm using?
Yes, because the laptop you're gonna talk to me here, and the game you're going to play on your phone.
Oh, okay. Thank you.
Is anyone stuck? Anyone confused on how to play Kahoot?
Yes, Dr. Lopez.
Hi.
I want to know how to. I have downloaded the Kahoot app, but how do I check if it's or not?
Do this now. Open your camera.
Okay. On where? On Kahoot?
Yes, on your phone. Your camera for your phone.
Yes.
I don't know. Anyone play with the Kahoot app? I know some people did here.
Okay, so
Yeah.
Go ahead. Explain to her. I haven't.
Okay, so in the app, if you have the app, you go right to it. Sometimes it has an ad, you X out of it. When you go to join, it's this multicolored box. You click that and you add the game pin in, which is 113-9878. And it's always located in the bottom left screen. So even if something happens, which sometimes it does, you can always get back in.
Number again?
Right
It's
here on this screen.
113-9878. Once you do that, once you do that, it will pop up saying, hey, what's your nickname? You type in anything you want. And then when you press yes, it will say, you're in. See your nickname on screen, ? And then you look and you're like, I am. Perfect.
Sounds good.
Yes, thank you.
Well,
And one of the advantage of doing that is that it saves the game for you. What we'll be doing now is recording and send it to everybody that did not have a chance to attend today. So you have it on the YouTube channel and be able to watch it. But quite honestly, if you have the app, it's easier. Okay, so you should see a name here. So we'll be getting started in 2 minutes, guys, or 3 minutes. But just want to give the opportunity to those that never played to join, because once the game starts, I can't stop it and explain. So now it's the last time you can ask how to join.
Now, if you join, how do you participate in the game? I just have a list of names on my screen here. So how do you? I have lots of names lined up on my screen, and my name at the bottom. So what happens?
So once the game starts, you have 4 color boxes that you can pick the right answer. So you play on your phone. It's an interactive game.
Okay. All right.
All right. So just hang it tight. I always give a little bit of time for the people that are coming in, and might be late. It's always a good idea if you are first time playing. None of you guys are already here, I guess, to come in a little early because we can explain it how to play. All right, so now we gave it 5 minutes grace period. We're about to get started. So if you are new to Kahoot, you play on your phone. The reason why we do Kahoot is to get you off of thinking and acting fast. So you play Kahoot on your phone, you select the answer on your phone, not on a computer, okay? And then you only have 1 minute per question. Now, here's the thing about Kahoot. It does not allow me to give you a long answer. So sometimes they'll be abbreviated or might be some misspelled words in there because I'm trying to shorten the words because it only allows me few characters. Do your best to understand what's the meaning of the answers, and good luck, everyone. Now, last thing is, you're on top of your game if you make the podium. Okay, it's very hard to make the podium because there are what 92 of you guys playing here today, right? That's a lot of people. Now imagine if you are the top 5. That's like incredible. Out of 100 people, like that's the 5%, right? If you're not there yet, aim to be the next time, and it's okay. Nobody has ever got to the podium the first time they play out of the blue. It's a process. It's a process that you learn as you go, and the more you do, like Rachel did the question bank like 4 times or so, no one can stop you ever again, ever. If you keep putting the work and showing up and asking questions, this is going to be the last test of your life. You don't have to, at least not for your credentials anymore, right? All right, everyone, good luck. I am about to get started. Please, please, please do the diagnostic test before in a timely manner. We have 4 of them, so you should do them at least 10 days before, start doing them 10 days before your test date. It will pay off hugely. I cannot even express how easy your test will be if you follow the program. Okay, that's it. Let's get started. Good luck, everyone. So this is about what we learned yesterday. So if you were in class, bingo, should be easier. Okay, very hard question. Very hard question. Can someone tell me why olanzapine is the right answer?
Because they're
You can
acute,
bring it. Can I answer?
they're experiencing acute mania.
Okay, all right, very good. That is partially 95% correct. It's true, but it
I
still
put
doesn't
it,
answer the core
is
of the
it because
question.
it's faster acting to start them with the Zyprexa or the olanzapine and then you move to lithium if needed?
Perfect.
Okay.
Perfect. So yesterday we covered this content and I tried to allude to you guys that lithium, it is the golden standard for mania. But think of this way, what is the window for lithium? Is just 0.6 to 1.2. Can you raise lithium fast? No, you can't because it has a narrow therapeutic window. What if you give too much lithium and now you are in lithium toxicity, right? So the practice, unless if you want to keep this patient in the hospital for 3 weeks, right? Just joking. You start with a antipsychotics, bring the mania down, and then you switch to a lithium. So a lot of people do Zyprexa in practice, olanzapine in practice. I prefer quetiapine, but that is not right or wrong one or the other. They both are good. Okay, they both are good, and that is not the only ones we can use. We can use many other choices, but for the test and specifically real life, consider a antipsychotics because it covers the mania, and then you switch to lithium, for example. Lithium is very good for bipolar mania, not so much for bipolar depression, right? Which is bipolar 2. So I'm glad that that some of you guys got this question incorrect, which is a great thing. Okay, why? Because we learn from mistakes. This is human nature. Hopefully now you will not miss a question similar to this on the board. So rejoice on your mistake. Don't be sad if you got it wrong. Learn it from it and get it right on the test. Okay, next question. Oh, here you go. I even put in a little explanation because I think this is one of the hardest questions, because we hear lithium is the gold standard, right? So why not lithium the correct answer? So antipsychotics can be faster acting, right? All right.
Dr. Lopez, we cannot see the question being generated on the computer screen.
1 second.
I'm able to see it.
Once that we play in the game, I can't stop. So give me a second.
The question is on the computer.
All right, so I'm not sure why some of you guys are not able to see it, because I am presenting.
I can see it, Dr. Lopez.
You can?
Yes.
Okay. So not entirely sure.
I had to log out and log back in.
Okay.
So just an FYI.
Okay, good. All right, so remember what we talked about: tolerance, dependence, addiction, kindling. All these things are somewhat similar. Make sure you know the difference between tolerance and addiction, dependence, and withdrawal, right? So tolerance is the easiest, is needing more of the same medication to achieve a effects as they did the first time, right? So this is one of the reasons why over time, not for the board, right? Over a year, someone that were doing well on Lexapro, they may not be doing well on Lexapro. For the board, when someone is on a medication and doing well, and all of a sudden is not doing well, you say, what is my psychosocial history? Oftentimes, you need to assess what else is happening in their lives at that time. The medication was working. What else happened? Did another medication was added to the regimen? Or is that a psychosocial issue going on? Okay? Real life, you can increase the dose pending that nothing else is going on. Okay, so pay attention on that one because oftentimes questions related to that may be on your test. I don't know. All right, next one. So I took the time to kind of really write down dependence, withdrawal, and tolerance for you guys here because I think this is a very important distinguish to distinguish them. Okay.
Dr. Lopez, I have a question.
Sure, go ahead.
When you choose the answer, how do you do? Because I choose that fast, but
you select on your phone.
I select on my phone, but it's giving the answer late.
Not entirely sure how to help on that one. Okay. So as long as it records the answer, you're okay. All right.
I just select it. That's all.
Okay. If you just select it, once the time is gone, it doesn't count. You have 1 minute per question. Next question here now. See if you can select it early before 1 minute. You see a timer on the screen. Here's your timer on the left-hand side. All right, you got 5 seconds. Pick your answer. All right, so everyone almost picked ADHD. I trust that those that did not, it was a mistake. Maybe you clicked the wrong button, right? But if not, here's the rationale. She has all the characteristics of ADHD. Yesterday, we mentioned there are 3 types of ADHD mainly, right? Inattention, impulsivity, and hyperactivity, and combined. It's very important that you understand each one of those categories because what if the board asks you which type of ADHD is presenting in the scenario? Very important to know what part of the brain ADHD is affected by, right? So that way, you know those kind of easy question if you have gone through the course and you really highlighted those important things need to know. Okay. As I mentioned all the time, please print your PDFs. Once you have gone through the videos and the live classes, the PDFs should be no more than 40 minutes to go through a whole module. No more than 40 minutes. As long as you're doing continuously, there will be 107 questions per ANCC blueprint from modules 1, 2, and 3. So what does that mean? That's where you need to spend your energy at. How convenient, we just talked about this. Okay, we got 35 seconds left. Two, 3, and 1. All right, so glad that the majority of you guys really pay attention on what I said yesterday, because it kind of makes sense. You're giving something that is hyperactive, because the hypoactivity in the prefrontal cortex, right? So very important, okay? So hypoactivity in the prefrontal cortex is postulated to cause the inattention, for example, in ADHD, right? Functions like attention, impulse control, and working memory, okay? Now, just to clarify, right? When we have the prefrontal cortex, we have the dorsolateral and the orbital frontal, right? So here it says hypofunctioning of the prefrontal cortex. So let's break this down. Inattention, dorsolateral. Impulse control, orbital frontal. Is this important? You better believe it is. Okay? And what else is inattention? Anterior cingulate of the limbic system also helps those with the inattention. Is also postulated that is a portion of that. So I would know those three uh, functions that I just mentioned. Okay. Oh my God, I, I promise I don't remember that I actually did this because it's been a while. But look at this, the dorsolateral. I don't remember. I honestly don't. I mean, I spent until midnight or so, but I guess I'm in tune with, because this came as a surprise too. So anterior cingulate, but I didn't do the orbital frontal. Okay, so just write down orbital frontal, okay? But anterior cingulate has to do with impulsivity, the dorsolateral, the inattention portion. Okay, great. All right. All right, got 5 seconds. Pick your best answer. Okay. All right. So yesterday we kind of went over this a lot too, right? That it does not matter for the board how well the medication is working for ADHD. It doesn't matter. You can give the kid ADHD medication and they come back as the best kid, the smartest kid, the most well-polite kid ever. But if they develop a tic, I don't care if it's a blinking of the eyes tic, you switch, you stop a stimulant and possibly clonidine or guanfacine. So why not Strattera, right? Strattera is a non-stimulant, but is now well known to be good for, sorry, 1 second, guys. It's now well known to be good for tics, okay? All right, so again, it's good if you got it wrong because next time you will not, okay? Okay, guanfacine or clonidine, okay? And remember the age, right? Remember the age, sometimes the age can come in play. What if it's a 4 years old? What do you do? Hold on a second. All right. So basically here, we're looking for something that helps the parents understand a little bit of the condition, right? So by providing psychoeducation, it does the foundation for more of a holistic and managing of the ADHD. Now, usually, maybe the question could have been better written. Okay, so usually this comes in play. The question should have been better written for sure. When you provide a diagnosis of ADHD and the parents break down. Okay, at that point, your goal is not about the medication or even the treatment. Your goal is to educate the parents and provide brief supportive therapy. Okay, it's not even so much psychoeducation. That is a very common practice in real life. Okay. So brief supportive therapy for the family if they become distressed during the ADHD diagnosis. In fact, that is probably the most high yield thing about that question is right here in the bottom. Okay. So we will get 100% right on this question, right? Okay. Almost 100%. So that's good. That's good. We're almost there. Okay. I was going to say if you pick ECT, you're going to lose your license. Okay. Basically, the main course of action is DBT, right? DBT is for borderline. Not even medication is the main course of action, just like PTSD. Sure, there is Praxil, and sure, there is Zoloft that are FDA approved. But even so, it's not the main component of PTSD. So when we talked about DBT, you gotta think who created Marshall Lineham and what is the goal of DBT to decrease suicidal behaviors or risky behaviors. Okay, so that is very important. Yeah, I know you guys are laughing, but I was like, oh man, hopefully nobody pick ECT. I was crossing my fingers here, like, please don't pick ECT, don't pick ECT. Okay, don't pick that answer. Sometimes people pick that answer, but it was a fast finger. Now, let's talk about something very important, diary keeping. If you see on your board question that says diary keeping as defined by DSM-5, that is not a borderline personality disorder, okay? So that is not borderline personality disorder. So what I'm trying to allude you to, diary keeping is very important with the diagnosis of borderline personality disorder. However, it is not defined by DSM-5 that it must have one. Which condition is defined by the DSM-5 that diary keeping is a must? Yes, PMDD. Okay.
PMDD.
So everybody, please give me a thumbs up if you understand that, because that can be confusing, because I say all the time diary keeping, but it is a highly suggested. If the question says defined by DSM-5, please do not pick borderline. Borderline is the answer, kindly. Thank you. All right, great. Oh, I don't know what happened to the music. All right. So the best thing ever since sliced bread, it is the narcissistic. Were you guys able to see the music, or just my song, my volume that went down?
No music,
No
but it
music.
is better. It is better
Okay.
that way, Dr. Lopez.
Okay. I like some excitement. I don't know. I like the music. I can't, that's Kahoot. That's on Kahoot. That's not on me, guys. Okay. Okay. So if you notice, narcissistic, they have a tendency, or some of the things they share commonalities with uh, antisocial personality disorder, right? If the board asks the number one psychiatric condition that are most likely to have homicidal ideations or intentions, that would be antisocial personality disorder, right? So just be careful. Narcissists think of it as the best thing ever since sliced bread, right? They want to everybody to say how good they are, but they don't want to put the work. They have this sense of a self-importance, like nothing will work if I'm not around, which is not true for anybody, right? Things will keep on moving as they are, whether we are here or not. That is the truth. Okay. All right. Next question. Okay, we got 20 seconds. Pick your best answer. Okay, everybody did pick their best answer. We got 10 seconds left. Okay, so who can tell me the difference between schizotypal and schizoid? Go ahead, Drupat. If you lift your hand, I'm not sure if it was you or not. Or maybe Alicia.
Schizotypal. Okay, should I continue?
Yeah, since you want to go ahead, please.
Yeah, schizoid has no feelings about what people think about them.
Schizoid, okay.
Yeah, they don't feel any remorse, not remorse, but they have they're indifferent to people's reaction to them. But for schizotypal, they have odd beliefs. They believe they believe that anything that is done outside is referred to them.
Okay, I mean, it can be. All right, can somebody else give a different differentiation?
So, schizotypal,
Oh, there's a
Okay.
couple people.
schizotypal want to be with people, but they feel odd.
Okay.
Schizoid does not want to be with people at all.
All right. So let me ask a harder question. What is
Yes.
the difference of schizoaffective and major depressive with psychosis?
So with schizoaffective,
affective, the psychosis is always there.
Okay. And
the other one,
major depressive.
psychosis, is only with depression.
Okay, perfect. Guys, you need to know those 4 definitions, okay? They are very, very important. Very important.
Can you repeat that again for psychoaffective and MDD, please?
Can somebody else actually do a different input on this?
So she, if I can reiterate, which is
Yes,
also
please.
reiterate,
Yes.
is schizoaffective. The psychosis is always there, but with MDD, with psychosis comes about when they have depression symptoms that come about. Is that correct?
Absolutely. So they are in the dump. They may have psychosis, right? While it's schizoaffective, the psychosis is there even if they are not affected, for example, by their mood.
Yeah.
Okay.
Even when the mood is lifted.
Yeah, even when the mood is lifted, they may have, psychosis. But why would that not be then schizophrenia?
Because schizophrenia is both positive and negative symptoms.
Okay. Okay. So what is a brief psychosis? What's a brief psychotic break?
Less than 4 weeks.
Less than a month.
Okay. What is schizoform then?
Less than 6 months.
Less than 6 months. Okay. I think that's enough, but these are very good definitions. Okay. Please, please, please note them. They can come handy.
Dr. Lopez, I have problem, please.
Okay, what is your problem?
My daughter called me and maybe they kick me out. I don't know. I don't see cow no more.
I'm about to play it. So you see a screen here?
Oh, I don't see it.
Okay, you may have to rejoin then, okay? Can't help, but I can put the code for you to rejoin by the link, okay?
Okay.
Okay, so
Thank
schizotypal.
you.
My pleasure. Magical thinking, right? So that's easy to say. Schizotypal, magical thinking, unusual perceptual experience. Okay. All right, let me put the link for you, and you can join by using the link. All right, 5 seconds, pick your best answer. All right, very good. So a little story in the back end. During my clinicals in my school, we were required to do 2,800 hours of clinicals, right? And they send us to different hospitals and so forth. And on the last year, I moved to North Carolina and I left my family in Maryland. And one of my roommates, it was a high-ranking personnel. And as I lived with him, I could see some patterns on him. So I opened the DSM-5 and I asked him to read obsessive compulsive personality. This is a personality disorder. And he said, "Are you pulling my leg?" Because that was him by the definition to every step. You know, he was a guy that earns a relatively large amount of money, but he was so cheap, that it hurts. He was so controlling about everything, not only organization, but papers were due, but he was so preoccupied with being perfect that oftentimes he would not turn in the papers on time and end up being deemed, right? So that is obsessive personality compulsive disorder, right? That is very different than OCD in itself. Okay. And remember, we talked about yesterday, the OCD can have tics. Do not jump into Tourette's. Read the question carefully because OCD can present with tics as well. Should get 100% on this one, right? Okay, almost 100%, right? So that is all the pictures, everything lines up with autism, right? Or in this case, lining up cars, toys, very specific. Um, their interest may be very different than others. They like a schedule, right? If the breakfast is 7 o'clock, God forbid if it's 7:05, they will notice. Okay, so very insistence on the sameness, right? Fixed interest. Some we talked about no cooing by age 1, no sing words by 16 months, little or no eye contact. Hey John, and John doesn't look, right? So that is all the characteristic of autism spectrum disorder. What's the gold standard? ADOS, um, ADOS, sometimes ADOS G, but you need to know not only the acronym, you need to know the acronym, not the name, because the board most likely will not give you this portion here. So you get 4 choices. They're acronym like. Guess what? If you, oh, I got it because it's easy, it has autism, diagnostic, observation, schedule. This will not be on your board. Now you are faced with 4 answers. There are likely acronyms alone. So please memorize, understand the acronyms. They will likely to be on your board. Okay, so that's applied behavior analysis therapy, right? Very powerful, very popular too, right? In real life, ABA, I would say this is pretty much the standard, right? For those with autistic spectrum disorder. This is very popular in real life and on the board. So I would know um, ABA as the therapy of choice for autism spectrum disorder. Okay. So don't pick ACT again, right? Can we get 100% on this one? Okay, let's say I am a high schooler, right? And I have no idea anything about nursing or psychiatry at all. I would look at the question and I'll try to match with one of the answers in the bottom. Let's say I have no idea about anything. The question said mood fluctuation. Which one has mood in the answer choice, right? I know that's a poor, very poor way of selecting an answer, but I'm just saying sometimes if you are absolutely stuck and you don't know where to go, look at the stem of the question. Your answers might be showing up in one of the answers choice, right? Now, that is the worst possible way of answering a question for the board. You are about to be the cream of the crop in psychiatry, right? So that is your specialty. You don't have to know much about the heart, the lungs, all the other body parts. All you need to understand is the brain and how the medications work and provide therapy and so on. So you really need to invest on your education to the core because you will be taking time, you'll be dealing with patients that need your help. Okay, it's very, very important. DMDD or bipolar, you give a mood questionnaire. DMDD or bipolar. Here's your mood questionnaire before the patient comes see me. I say, I'll leave the patient over there. I say, hey, X, Y, and Z, can you take 5 minutes to complete your mood questionnaire? That is very important. Okay. And remember, 6 to 17, and that's how we differentiate bipolar from DMDD. What else do we do? We screen for family history of bipolar. Okay. Now, oftentimes we prefer therapy than to initiate medication in younger kids. See if the therapy will be helpful rather than initiating a mood stabilizer or antipsychotics or SSRIs at the beginning. Okay. All right, so we got it. This was kind of an easy one, right? SV is not letting go of her first place. Frank is coming up. Marcia, Marcia, I know you are. I think you are testing very soon, so good luck to you, Dilu and Son. So, um, for the board, be on a watch out on the most likely diagnosis. This case, it almost give you the full DSM-5 criteria, right? 2 weeks, 5 symptoms, and so forth. Now, if the board only give you 3 symptoms and doesn't necessarily tell you 2 weeks, it still could be DMDD. Questions with DMDD, the answer, especially if they're older, I don't know, I don't want to try. They easily give up on anything that you ask them to do. Eighteen seconds. Okay, so if you pick D, if you'd like to raise your hand and tell me why D over A, if you want to. If not, it's okay. Now, just to go over this, right? In general, we start with SSRIs over anything else. Not that bupropion would not be a good choice, right? It could be a good choice in real life. It could be a choice. Now, there will be a choice if the presentation is low mood, feeling tired, lack of enthusiasm, or just losing the drive of doing things, or if the question is really related to sexual side effects. Because bupropion does not have serotonin, it's just norepinephrine, dopamine, right? So that could be a good choice. But in general, we always provide an SSRIs because they are the least medications to cause a cardiac complication. Specifically, fluoxetine, Lexapro, and Zoloft, okay? And self-harm, I'm sorry, in case of overdose, not cardiac complications. All right, great. So let's talk about something that a lot of people get confused. Who thinks that serotonin SSRIs, is it a dopamine antagonistic or is it dopamine agonistic? Who thinks it's antagonistic? You do? Okay. All right. Sarah Samuel saying it's antagonistic, right? Henrietta says no. Susan says yes. Who wants to tell me why is it antagonistic? Julie, Yuri, Judy. Anybody want to give it a shot? Who can tell why is it agonistic then?
Repeat the question, please.
Yes. Let's
Because
say Zoloft, Lexapro, Prozac. Is it a serotonergic antagonistic or is it serotonergic agonistic?
Isn't isn't
Go
it
It's
ahead.
just that it's
agonistic.
Agonistic.
isn't it that it's like an inverse relationship to the serotonin? So it increases serotonin and inhibits the dopamine.
It increases the serotonin, doesn't it?
Yeah, it increases serotonin
Okay, it does increase the serotonin. So would that be agonistic or antagonistic?
so
It's
it's
an antagonistic.
for
And
dopamine.
antagonist is ANTA, like against it.
Agonist.
Antagonistic.
Okay. So what is referring to? It is referring to the transporter of being back and destroying the serotonin. It serotonergic is agonistic, a cause and effect, positive effect. But now the transporter is cutting off, so that is no longer being destroyed. But the serotonin in itself is agonistic. Okay, so I just want to clarify that because that can be a bit of a confusing because serotonin, norepinephrine, the reuptake inhibitor, right? For example, SNRIs. So it's inhibiting the transporter that takes the serotonin back and recycle it. Okay, so in itself, it is agonistic, but the transporter is inhibiting the coming back and breaking down of the serotonergic neurotransmitter. Okay, just a little back end of the story why, if that is helpful to anyone. Note, oh my God, what did I do? Okay, note the difference between serotonin norepinephrine reuptake inhibitor versus norepinephrine dopamine reuptake inhibitors like bupropion, right? So if the question asks about pain, SNRIs are your best choice, Effexor and Zymbalta. Now, Effexor, real life here, people often say they cannot miss their dose. So be on top of that, right? If they do miss, I know you may not be able to control all the patients, but if they miss a dose, that is the one medication they usually come back and say, I feel brain zaps, and they really do. Okay, not to scare anyone, but it is a definitely a medication that you do not want to miss. Okay, all right. Somebody said C. Did any of you guys get confused with another medication or? All right, let's talk about C for a second. Which medication can, this is a hard question, which medication can show up in the x-rays as in glass-like interstitial lung disease? Glass-like, I call it glass-like looking. If you look at the x-rays, kind of like all foggy.
Is it like Prozac?
No, not Prozac.
Effexor. SMRI.
Paxer.
Effexor.
Infection is
Oh,
a rare condition.
yeah,
It's rare
so
side effect.
yeah, so Effexor, duloxetine. So know that because although very uncommon, it's something that is particular to those medications. Okay, so note that. Now coming back to Wellbutrin, eating disorders would be contraindicated, right, for Wellbutrin, and so would be someone with
Seizure disorder.
seizure
Seizure.
disorder. Yes, seizure disorder. Okay, SV. You don't want to let go of your first place. I see that. Okay.
Dr. Lopez,
Hi.
can regarding the previous question, can you say TCAs are also for neuropathic pain?
Yeah, you can. But in between a TCA and a Zimbalta, you want to pick a Zimbalta. Why? Because cardiac complications. That is really why. There is more side effects with TCA. Now, absolutely, absolutely, you can pick a TCA. TCA is well used for migraines, right? All right, next one. All right, we got 8 seconds. 5, 4, 3, 2, 1. All right, so almost everyone, right? Encourage the patient to engage in mindfulness meditations. Probably not a good idea this time, although I love it. It's not probably the best idea. Refer the patient to an outside psychotherapy program. Not if they already have a plan, right? They have a plan and they want to do it. Probably not a good idea. Now, for the board, anytime, right? So never pick safety contract. Now, safety planning, it's always a good idea. Obviously, I think at this point she has a plan. She's bent over that the person is going to, thinking about it. It may be past the time for safety planning, right? But anytime you hear suicidality, see if there is an option for safety planning. Never safety contract. Never. Okay. Sorry, that's supposed to be. All right. So I wanted to pull up my medication book here. 1 second. Let's see. What does it say about Latuda? Okay. So I'm using Stall. I use Stall on my phone, right? So it says here, FDA approved for schizophrenia age 13 and over, bipolar depression, monotherapy, age 10 and older, bipolar depression, adjunct for adults. So it is the medication, one of the medication of choice for bipolar depression. Everybody knows that lithium is not a good medication for bipolar depression. Let's see valproate. Let me pull it up here for you. Acute mania, complex partial seizures, simple and complex in absence of seizures, multiple seizures type, migraine prophylaxis, maintenance treatment. Then it says bipolar depression, but it's not FDA approved, but can be used as off-label. Psychosis, schizophrenia as an adjunct. The FDA approved would be antipsychotics. Latuda in this case would be an FDA approved medication for bipolar depression. Okay, so very good for that
Can I ask a
instance.
question, please?
Yes.
So it says mood stabilizer, and then it gives those as examples. So I don't know if the question said anything about being FDA approved. I'm just trying to find out,
Yeah.
why
Well,
that
in
would be.
between FDA approved and not, which one would you pick?
Okay.
So, yeah, it's close. Now, let's pull here Latuda. I'm sorry, lamotrigine. Lamotrigine, treatment of bipolar 1, partial seizure, general, conversion, monotherapy for adults, receive treatment, and so forth. It does not say bipolar depression. It's well used in practice for bipolar depression, but it's also not necessarily a FDA approved. Okay, so a great choice. It is Latuda. So now, what is one thing that's particular to Latuda or Geodon?
Dr. Lopez, I'm sorry to interrupt.
Have to eat.
Can I ask you a quick question since you
Yes.
brought up lamotrigine? I can't say that, lamotrigine or whatever.
Lamotrigine, yes.
Yesterday you had said something about that one for metabolic syndrome, and also if you're thinking about becoming pregnant.
Mhm.
But isn't Latuda also okay if you're pregnant?
No, but it depends, right? So it's all about risk benefits. No antipsychotic should be okay for someone trying to conceive if you can plan ahead. Now, Latuda, it is the most well used studied drug for someone trying to to have a baby. So is Zoloft. As much as that I get so many referrals for someone's trying to have babies and they are on escitalopram or Prozac, probably will be okay. But the most studied one is Zoloft, and I want to save my license and I want to follow exactly what it says, because as soon as you mess with the mother and the baby, that could be problems. That could be big problems, okay? Latuda is FDA approved. Great question, by the way. And as we're talking about Latuda, remember, and Geodon, as someone mentioned, give it with food, okay?
Right.
Give it with food. So very important.
Okay, thank you.
My pleasure. TSH is low. Okay, 100% or close to 100%. Wow, that's very good. So I did not see your hand there shine. Do you have a question? Okay. And I think Alicia and Group at your hands have been up for a while. Is there any specific issues or concerns? I think it's been up since the beginning of the game, so I imagine you don't have a question. Okay. Yeah. As we talked about yesterday, make sure you know hyper and hypothyroidism, and you make sure that you know well, right? These are, it takes a little bit to really get to know this content, but once you know it, it's guaranteed point on the board, right? Study for the board on the last minute. It is a sure recipe for failure, right? And even so, if you study quickly, just to make it through it, and you don't make it, you jump to another board. You go from ANCC to AANP. The results is likely to be similar results. Take your time, digest the content, learn the content, learn for what you will be doing, not just to pass the board. Take your time, right? Spend 10 weeks, spend 12 weeks if you want to. Or spend a four weeks, but a solid 4 weeks, okay? All right, so close again to 100%. So I see you guys are really getting in this. Easter, you have a question there? See your hands lift. Not sure. If you do have a question, it's a good time to unmute yourself. As you think of hypothyroidism, think of cold and slow. They get constipation, they are fatigued, they are tired. They do not like the winter, right? And hyperthyroidism, they do not like the summer, the heat. They eat, and they still very skinny, okay? And they are out and about and have insomnia. Okay.
Hello.
1 second, my dear. Next question, it will give you opportunity to talk. All right, got 10 seconds left. Okay, great. I'm very, very happy to see that everyone really got this. If you see on the board 6 months, that is high yield for generalized anxiety disorder. 6 months is really give you 90% of the question there, okay? So look out for 6 months when it's referring to generalized anxiety disorder, but don't memorize 6 months if it's talking about depression and so forth, right? It has to match generalized anxiety disorder. Easter, you have a question?
Yeah, my question is, I'm driving. I don't know what the questions are. I'm just wondering, is it recorded? Can I find it somewhere? I'm listening to all the answers.
Yes, we'll be sending out a link to this. It'll be on YouTube, and you can rewatch it there. Okay.
Oh, all right,
Pay
thank
attention
you.
on the road. Pay attention on the road. All right. Okay. Focus. Here you go. Next one. It's supposed to be panic disorder, okay? Not disdain. Just FYI. Okay, great. Judy, you have a question? Okay. Why does it matter if it's panic disorder versus panic attack?
For me, I feel like what gave it away was the acute.
Yeah.
So I'm like, this is an attack. So.
Okay.
First occurrence.
Yeah.
Dependent.
Yeah, but why does it matter?
Because a panic disorder is specifically like reoccurrent in nature, so they're going to have it multiple times, however often.
Okay, but why does it matter though? As far as the treatment that you are going to do. That is what matters for us. What do we go ahead?
Doses they receive should be higher.
Not necessarily, but halfway right. Let's put it this way, halfway right. What is the treatment of choice for
SSRI.
SSRIs? What's the treatment of choice for panic attack?
Hydroxyzine.
Yeah, I mean,
Benzo.
honestly, for the board, you can pick. Yeah, you can pick hydroxyzine even over benzos for the board, but in real life, benzos probably more prescribed than hydroxyzine. And the reason why you pick benzos for the board most likely is because benzos can be very addictive, right? Start with a low gun. If that doesn't work, you increase up and up and up. Okay. But it can be confusing. That's why I wanted to emphasize the why, because the why matters to us. We can say, okay, panic attack is one time. Let's try hydroxyzine next time you have a panic attack. I do this in real life all the time, right?
Dr. Lopez, can we do a beta blocker, like propranolol?
Yeah, you can do a propranolol. Some people prefer that. But in which patients would you not prescribe a propranolol?
Asthmatic patients.
Yeah, just be on a watch out for that. That's something good to know, okay? Because it can cause bronchoconstrictions, right? I guess we gave away this answer, didn't we? Can some of you guys read the question super well and maybe select a different answer? This is an acute panic attack, not a panic disorder.
benzo.
Yeah, I got it wrong. Yeah.
Yeah. All right. So why I wanted to emphasize reading the question well, because I noticed somebody said A or C, even though it's misspelled, that would be a great choice for a panic disorder, not a panic attack. Now, I can see why a lot of people pick benzos, and you're not wrong, right? But for the board, usually hydroxyzine can have a anxiolytic, reducing anxiety, and is less addictive, right? So someone's having a panic attack, they may benefit from hydroxyzine. It's like, think of this way. If you can manage with a less potent medication that does not cause addiction per se, then it's probably the best treatment. If that doesn't work, then the lorazepam could be the next best option there. Okay, but because of the risk of dependency, may not be the best option right away. Now, in real life, you get more questions from the patients, you collect more of an assessment, and you make your best decision at that time. Okay. I think Easter, I'm not sure if you have a question or somebody else. Derico,
Yes, I have a question, Dr.
yes, go
Lopez.
ahead.
I'm kind of confused between this hydrogen, hydrozazine, and the benzo. Can you explain a little further, please? I'm kind of confused. Which one to use for a panic attack and the one that is for panic disorder?
Okay, can someone else give it a shot at this explanation?
So panic disorder, you automatically go with SSRI long term. The disorder also says it's reoccurrence, and SSRI is what you do. But for a panic attack, you would go for the board hydroxyzine, and that's why you would have benzos later. But really try to think about the hydroxyzine for a panic attack.
Okay, all right. So that's well explained, and I definitely agree with that. I do this all the time, okay? I do hydroxyzine actually in real practice. I do not like benzos. I absolutely do not like benzos because I have seen so many patients come to me with tons of medication on benzodiazepine for so many years, and they hate me because I do not prescribe benzos. Now, is that true for everyone? No, but a lot of providers do prescribe benzos in hopes to do good for the patient, but they may end up being dependent on it, and being off benzos is horrible. So how you have to titrate benzos is a pain on you and on the patient. You have to do it so slow over months to get the patient off of benzodiazepines. Okay, not saying that I do not. I prefer not to prescribe benzos. Okay, I said, well, you can go to somebody else. Now, some people do need benzos, right? And they do prescribe benzos. It's just not. My first thought is, let's try something else. Okay. Alicia, do you have a question?
What would be your dosage for hydroxyzine for panic attack?
I do 25, but you're not wrong if you go to 50. But it's such a thing that I have someone that have insomnia and she had some anxiety too. I gave her 25. She said it worked too well. I went to sleep, and it was only at 25. Not only, but you have a dose of 10, 25, 50. You for somebody that's very anxious, you can even do 25 4 times a day. It would work, but that's, again, that would be a complement to the baseline. I like hydroxyzine as a complement to a SSRI. I'll add, if SSRI is not working, I usually add Buspar to that. And after raising my SSRIs to a appropriate level and given time, I add hydroxyzine. That doesn't work, I keep increasing. But usually I go with an SSRI and Buspar for anxiety in general. Okay.
Excuse me, Dr. Lopez,
Yes.
for hydroxyzine, so is it like off-label use for panic attack because it's not
Yes, it is. So let me pull it up here for you. Let me kind of read it line by line. One second. So, anxiety and tension associated with this psychoneurosis. Adjunct in organic disease stress in which anxiety is manifested. So that is the reason why. So it just says in as an adjunct, right? As a second time. Pruritus due to allergic condition. That's probably is the intention first, right? Itching because it's a antihistamine, right? Pre-medication for sedation, sedation following general anesthesia, anxiety withdrawal symptoms in alcohol patients with delirium injection format, adjunct in pre and postpartum patients to allow anxiety control, amnesia, and reduce narcotic dose, nausea and vomiting, right? And insomnia. So if you think of a histamine, what the histamine does is keeping you up, right? Histamine during the day, well, it starts during the day full and it keeps going down, down, down. And at night, it kind of shuts down so that way you can sleep. Another way to do that is to start with the antihistaminergic medication. What happens when you give Benadryl, right? People go to sleep. So it is an antihistaminergic properties that can and is very effective for anxiety reducing properties.
So I have one question. So for ANCC, if we get a question, do we choose the F because FDA approval is for using benzodiazepines? Do we choose benzo or hydroxyzine?
Choose hydroxyzine because of less risks of dependency.
Okay.
Right risk. So yeah, definitely benzos work. It worked really well. You know, that is
Yeah,
the
it's hard with just this question only because when it says emergency department, which I have totally worked, and then depending on the symptoms, they're going to go for that because they're not prescribing it, but they're doing it in the immediate for
yeah.
certain relief, especially when you throw them on the monitor and you're seeing different signs of, cardiac issue and things like that. You really want to get them down. They do that. They spring it on. They have like no issue unless there's a there's a shortage, then they say, oh, forget it, we won't do that. But other than that, they always do. So that was my first thought. It's like, oh, emergency department, let me see that. I was thinking that, but I had, as you're saying, making sure that they don't want it in that, even if it says the ED itself like that. I just have to get my mind not to like draw to that. But that's all I was saying, where it's confusing, that's all.
Yeah, absolutely. It's a tricky one, really, because it works. It works too well, right? But there's so many people that are addicted to benzodiazepine that becomes a problem. Just like in the past, all of us have seen this. All of us, I guarantee you, pain is what the patient says it is. Here's the guy. What is your pain? 10 out of 10, and he's playing video game and eating. I'm like, 10 out of 10, sir? Yeah, 10 out of 10. And what happened? We have this huge epidemic of opioids addiction, right? So there is the fine line between doing what's right for the patient because pain is what the patient says it is. We heard that many times, but then we created the beast, right? So, things do change over time in your practice, but I do like hydroxyzine. Now, in the ED, they don't care, man. They want to take control of the anxiety and go send them home, right? So it's emergency kind of you're only here to treat this. Let me treat you, and then you go see your PCM, your PMHNP, to manage the condition, right? So they just want to kill it right there, and now someone deals with it.
Dr. Lopez, do you know how many more questions before we go?
One question, I think, or two.
Okay.
Everyone should get this one right as well, correct? I think we covered this very well yesterday. So even though it doesn't say clear by neurology here, but no physical examination reveals no neurological abnormality. So clear by neurology implied, right? So that is a typical can't convert. Remember that from yesterday? So conversion disorder, they show up with symptoms of a motor symptoms, blindness, paresthesias, paralysis. So that is, so what was the insult, the argument? And then the question said, after the argument, the patient had those symptoms of neurological symptoms, and there was no signs that there was a neurological problems. So that is it. So unfortunately, sadly, we don't have the music today, but Katie got the third place, Tiger, and first place is SV. I don't know who SV is, but you rocked today, so you did really well. Fab MP and N. Reality, all of you guys did well, right? It doesn't matter where you stand today. It's all about a learning opportunity. If you make mistakes, be happy. You should be happy and not sad, because now you learn from your mistakes, and there is something that you will not fall for on the PMHNP board certification. Please, please, please adjust your schedules to take the diagnostic tests before the board. It is, think of this as your opportunity to sit for the board 4 times before you actually sit for the board, that it is real board in one time. So by adjusting your schedule, you have a board date, then go down how many classes are you going to attend, what you are going to do on each one of those blocks or modules, complete your videos, complete your question bank, attend the live classes, schedule your board. It gets to be very real when you have a board date. For those of you guys that I know that are testing tomorrow, I wish you absolutely the best luck. Some of you guys already told you already passed, so you know who you are, so don't worry about it. Don't worry about a thing. If you've done the right thing, the result is natural. It will come. With that being said, let me stop the recording, and then we can ask any questions. There is no more cheat.